Hello and happy Teach Me Tuesday. My name is Lisa. I'm an experienced NICU nurse and an experienced NICU nurse educator here to break down another topic for you. And as you know, September is NICU Awareness Month. And throughout this month, we are just talking about a variety of NICU topics. Last week, we really dove into abbreviations. And today, we're going to talk about one of my favorite things that's not exactly clinical, but it's clinical in a way. And that is then versus now in the NICU advances over time. We're going to dive into kind of the history of our job, where this all started, where we're going, and how we can learn from our past. So, I want you to kind of think about this idea that adult medicine is always kind of in practice in a way, right? Even if you think back to Greek and Roman history, they were treating people, they were trying to make people better. There was old medications or medicinal herbs that they were using, right, to get people better. And they've always been trying to help adults. And that's true throughout all of history to present day. But the infant mortality rate has always been high because there was just nothing that we could really do for babies. And really, in the 1960s is when we really started having this idea of like, what is this and where does the world of the NICU come from? How can we improve the health and care of these babies? And what does the future look like? And 1960 is really only like 60 years ago. So the NICU is a very young profession, area of the hospital where people sometimes don't even know we exist. I don't know if you have ever experienced that. It's a young specialty. It's just completely evolving. And over time, like if you think about it, in the 1960s, they were working to save like 33 and 34 weekers. And now we're working to save 22 weekers. So it's just wild kind of how this has evolved over time. And that we're learning so much and so quickly that there's just so much more to come. So we're just going to go into 10 things that I think are really great that we've learned over time to really help the care of these infants and prolong their survival. Number one, protein and starter fluid. So we used to just start TPN with that was just sugar. It was just D10. A baby was born, an IV was started, maybe a UA and a UV, and they were given D10. We thought sugar is great, right? Sugar helps the brain, it's energy. But then we learned, like, oh, maybe we should be giving them some protein. And then maybe we even should start lipids. Nowadays, we're starting lipids on day of like one, right? So we've learned that early amino acids with protein is the best thing for babies. This started in the early 2000s during the Iowa trials with really looking at early protein to preserve lean body mass and support neurodevelopment because that's all we want at the end of the day is how can we make these babies better. So remember, in the early 2000s is only 20 years ago. For 20 years we decided maybe we should put some protein in here. So that's amazing. Central lines, infection prevention. It was kind of standard to just have a CLABSI every month, depending on how big your unit was. CLABSIs were kind of considered almost a rite of passage in the NICU. Babies were having infections all the time. And now if you have a CLABSI, it's like horrifying. We are so like digging into like, okay, what happened? Where did we go wrong? What steps did we not take? Did we do our central line checklist? All of these things because we know how detrimental this can be to babies. So not only that, but we've also gotten so much better with our use of antibiotics and making sure we're not overusing them and that we're using them for the right reason. So central line infection prevention is huge. Donor breast milk absolutely was not a thing when I started 20 years ago, 22 years ago. Never saw it. In fact, it was kind of considered taboo to think about using informal milk sharing where maybe you were like, I'm not making enough milk. I want to use this other person's milk. I remember the first time someone tried to do that during my nursing career. And yet, in the community setting, it was kind of considered more common and people were doing it. So we have gotten to this place with donor milk banks and donated milk where it can be pasteurized and safely stored and used for our babies. And these big studies and meta analysis show better tolerance, improved neck rates. And so for our VLBW infants, this is the gold standard now. Early colostrum care, really using colostrum to coat the infant's mouth, 2010s, 2015s. I mean, you guys, you have to remember how young some of these things are that we are doing. We know that digestion begins in the mouth. So if we can get colostrum care and do oral care with colostrum, we are starting to help develop those protective enzymes, such as the salivary IgA. And that's going to help them tolerate their feeds better over time and get better gut flora going for when we do start feeding them. So this is all part of those early feeding protocols in the NICU, which also ties into earlier and fortified feeds. We used to basically be like babies can't eat until they are older, like month old, I would say is probably on average when I first started. They did some large randomized control trials in the late 1990s, early 2000s, which really showed if we can get babies eating, it decreases their sepsis, it improves their growth, it shortens their hospital stay, but it was not increasing neck rates. In fact, one of the best things you can do to decrease your neck rate is to have a feeding protocol that is followed by all providers. If you have that, neck rates tend to actually decrease quite significantly. So just know that that's often why they're around is for that reason. And fortifying the feeds is also replacing what they were missing in utero because they are supposed to be getting this calcium and phosphorus burst in utero, right, in those last few weeks. And instead, we need to be giving that to them so that they can grow properly. Gentler, gentler ventilation and less intubations is a huge change for us. I was just talking to someone about this the other day. This idea that if you were born pretty much 25 weeks or less, we intubated you automatically. It kind of didn't depend on what you did at delivery. That's what we thought was best practice. We intubate, we give you surfactant, and then you tell us when you're ready for extubation. Now we really try to use CPAP at delivery until otherwise proven. And there are a lot of trials about this, right? Early CPAP use with the coin trial, this real idea of what can we do together with non-invasive um, surfactant administration to help these babies really have better long term outcomes, right? Decrease BPD, less lung injury, gentle ventilation, and you just quickly reminiscing on this idea of the pressures we used to use. We used to just use straight up AC mode, which is like every breath was supported. And sometimes the babies would be on like 30/8. So it's like we're giving them pips of 30 on tiny little babies. No wonder they had all this barrel trauma going on in their lungs. So work smarter. We've gotten smarter. We are using that gentle ventilation, whether it's an oscillator or the jet, to really support their developing lungs and to help prevent those long term outcomes. To me, I would say this is one of the biggest ones because lungs are really hard to grow. And so if you go back to this idea of early feeds and fortified feeds, we don't want to just have babies gain weight, right? We want babies to grow long because when they're growing long, that means their lungs are growing. And if their lungs aren't growing, then they can't overcome some of this damage that we've done because we have to do the ventilation. So, minimally invasive ventilation combined with less invasive surfactant administration, and then gentler ventilation when we do need to do it is just the gold standard. And I just am so lucky we live in a world where this is happening. Let's talk about family centered care. I have a friend who's in his 50s. He is a triplet. And when they were born, they were in the NICU. This was 50 years ago, about, I don't think he's exactly 50, but he's somewhere between 50 and 55. And his parents saw them at birth, when the mom was in the hospital, and then within the 48 hours of discharge. That was really it. Parents were visitors. They were not encouraged to come to the bedside. They were not encouraged to hold their babies. They were not seen as caregivers. They did not have shared decision making. And all of a sudden it was like, maybe this isn't the best. So over time, obviously parents became more involved. They started visiting more. And now we've gotten to a place where parents participate in rounds. We are open 24 hours a day. There's no restrictions on visitors. In fact, during COVID, many units had to explain that parents were caregivers. They were considered part of the healthcare team so that parents could be with their babies. And some units obviously had bigger restrictions on that, depending on where you were, what was going on with your COVID cases. But parents should not be seen as just this outside ancillary group. They need to be present from day one, not only for bonding and being present, but really for this idea of they don't want to be taking home a stranger, right? They need to be taking home their baby. They need to be part of the shared decision making and knowing what's going on with their baby long term. And it improves weight, it lowers stress hormones, and it reduces readmission. So, all great things, which combines with kangaroo care. In 22 years, I've seen a huge change in kangaroo care. I would say that we got babies out to hold who are on what we would call stable ventilator settings, which I can't even define for you what that was, but maybe on an oxygen level that hadn't changed in a while, or we hadn't changed their ventilator settings in a while. But pretty much, if you were in an incubator, we kind of thought you were too fragile to get out, and we kept you in your incubator forever. So we've definitely gotten to this place now where it is really the practice is changing that babies should be held within the first 24 hours of life, kind of regardless of what's going on, to promote bonding, control temperature, and to have cardiorespiratory stability. We have talked exhaustively about kangaroo care as a, NICU Learning Nest group. I cannot talk about it enough. In resource limited countries where they don't have incubators, babies are on their moms 24/7. Moms and dads, primarily moms, going to be honest. And that's how they stay warm. And those babies thrive. They gain weight better than babies in countries like the United States do because they're on their mom. The hormone regulation, the heartbeat regulation, they breathe better, they grow better. And that's really where this is translated to. So Cochrane Reviews and the WHO say this is the best practice. Kangaroo care early and often. And before it would be like, okay, we're going to do your kangaroo care for 1 hour today from 3 to 4. And now it's like all day, every day, peeps. Let's get in here. Let's hold as much as we can. This is our final kind of like aha for me and what has really changed over time. I just picked three medications. There are so many meds we could talk about, but three medications that really changed the NICU. Number one, and I'm talking about the NICU because we all know that maternal steroids is a huge one on there and that cannot be overlooked. We have to think beyond kind of like there's so many medications we can talk about. And yes, those maternal steroids are huge and a big part of this. But in the NICU, three big changes that have really happened. Number one is obviously surfactant, right? Respiratory distress syndrome was really kind of considered a death sentence. If you were born with that, there was really nothing we could do for you besides aggressive ventilation that just gave you terrible long term outcomes. But now with surfactant therapy, it revolutionized the survival of preemies and not just the survival, but their long term neural development and just morbidities, right? They just do better, obviously, if those kids that need surfactant get it. Next would be pain recognition and treatment. There was a major thought that babies didn't feel pain, that they just like didn't have pain receptors, and we figured that out and started treating it, right? So it was actually probably the late 1980s, early 1990s before pain was consistently treated in the NICU. And now we're getting better and better and better with the medications we're using to help prevent long term neurodevelopmental outcomes that are negative from, you know, opioid exposure in these babies. And then PDA closure medication. So babies that are born prematurely are likely to have their PDA remain opened. That's what the P of PDA is, patent ductus arteriosus. And surgery was the only option, but medications were started, such as indomethacin. In fact, indomethacin used to be used as a standard medication, like it was just given to every baby. We learned that babies will close on their own, and sometimes small ones can stay open, so we don't need to just give it to everybody. And we have new medications such as ibuprofen and acetaminophen that give non-surgical closure options to these babies. So these are just three breakthrough medications that really shifted survival and quality of life in NICU babies. So those are just 10. What can we tell parents, especially if they have questions about anything, or if maybe we're trialing something new? If we're saying, oh, we're trialing out this oral care where we're going to swab here. Okay, well, why? Why are we doing this? Tell them the history. Okay, digestion begins in the mouth. We're going to coat the baby's little cheek pads. Don't use the words like buccal membranes, right? We want to talk about things that they understand so that they can build up healthy bacteria, work on their gut microbiome, and even saying things like, for me, I tell stories all the time. When I started, we didn't even use donor milk. So now we not only use donor milk, but we can also use your colostrum to start this. And I also like to tell them, like, the NICU is young, it's changing. We are learning so much each and every day from either quality improvement projects or double blinded study type of things. So really encourage them to participate in this, even if it's like kangaroo care. I mean, I remember those first babies that we got out on the jet, man. We were stressed. We had like 20 people in the room. And the parents, I'm sure, were like, what is going on? They're so excited to hold their baby, but it was like our first time trying it. So, especially if you're trialing out new things via quality improvement or some other way, encourage their questions and let them know the why of what you're doing. So those are just my 10 innovations that I think have really changed the NICU world. I'd love to hear yours if you can think of others that I didn't mention today. But we have to stay current and change is going to happen. I hear about the idea of change fatigue a lot. And I encourage you to think about more that the NICU is young and we're learning each and every day. So that we need to stay current to the changes and adapt our practice as new evidence emerges. Like, that's our job as NICU nurses. We need to see how far we've come and how much more we have yet to even learn or practice. So during this, it is NICU Nurses Week. It's, during NICU Awareness Month, but this week and it's coming up on September 15th is NICU Nurses Day. I just encourage you to be open minded, to bring new ideas, to read research, and to think to yourself, like, what more could we be doing? How could this get better? Even this idea, not that we talked about this one today, but cooling, right? We've really only been cooling kids for about 15 to 20 years. That is a new practice to us. And those of you that work in cooling centers probably have really seen benefits to that. So just think about that. I assure you, when they first said, like, we're going to, first we've told you never let a baby get cold. Now we're like, we're going to go ahead and cool this baby down to 33.5. People would probably thought they were insane. So be open minded. Know that it can be exhaustive to have changes come all the time, but to learn the why, to understand the meaning behind it, and to be an early adapter. And if you have any great ideas, I hope you start to implement them and then publish, publish, publish. Have a great day. I'll see you next week.